Thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I am Kathy Riley, the Associate Director of Programs at CSCLA, and I'm honored to welcome you to this week's webinar titled A Guide to End of Life, A Nurse's Perspective. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs, such as this one. And if you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org, and we will put that in the chat as well. And before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but we'll get to as many as possible. Then I want to let you know that at the end of today's webinar, we'll be joined for a few minutes by Kristen O'Leary-Jones, our Cancer Support Community Los Angeles Director of Development. And she's going to provide some information about the Benjamin Society, which is a group of dedicated donors that have pledged to leave a gift to CSCLA in their will, trust, or life insurance policy. And I know you'll enjoy getting that information from Kristen and enjoy meeting her briefly. So let me introduce our wonderful speaker for today. Sarah Lowe is an oncology care coordinator with 12 years of experience in inpatient hematology-oncology, inpatient hospice, and nursing education. She has published articles on a wide variety of topics, including interdisciplinary collaboration, nursing quality indicators, and geriatric issues. Sarah is passionate about supporting patients through the entire continuum of care, and it gives me great pleasure to introduce Sarah. Sarah, welcome, and thank you so much.
Thank you so much for having me. It is my pleasure. I love talking about this. So the talk today is a guide to the end of life from a nurse's perspective. So just so you know, there is a very excellent talk by Karen Morin that was done with CSCLA and is available on their YouTube called Your Life, Your Choice, discussing end of life choices, which really focuses on advanced directives, Pulse End of Life Options Act, and I would highly recommend that. This talk isn't going to specifically be focused on those things, although I am happy to answer any questions that I can if there are some at the end. So we'll just go on to the PowerPoint. So yes, this is a guide to the end of life from a nurse's perspective, and there will be another talk on the series from a social work's perspective that is coming up as well. Okay, so the goal of this talk is really to discuss the role of palliative and hospice care, as well as their very distinct differences, review symptoms that may occur during advanced stages of cancer, and the interventions that may help alleviate those symptoms, and provide an overview of the general timeline of symptoms that occur during the weeks, days, and hours before the end of life. Now, there's not going to be any sort of graphic photos in this slideshow, but going through some of those things, particularly, those signs and symptoms at the end of life might be triggering to some. And if it is you, just feel free to just log off, and this will be recorded for you for the future whenever you're ready. Okay, so I would like to recommend this book to you all, A Beginner's Guide to the End by BJ Miller and Shoshana Berger. It is really excellent, and there's 2 chapters in particular that are going to correlate with this talk called The Dynamic Duo and Symptoms 101. And I just want to start out with this quote, which is, "There's nothing wrong with you for dying, but you'd never know it from the way we talk about death. We actually call it a failure. Her health is failing. He failed treatment. If you believe what you read, the entire enterprise of aging is optional. Eat kale, drink red wine, walk 10,000 steps every day. If we can't beat death, then clearly our character or will or faith isn't strong enough." And what about all those fighting words? Beating death, defying aging, the war on cancer. All battles we're sure to lose. Next to birth, death is one of our most profound experiences. Shouldn't we talk about it, prepare for it, use what it can teach us about how to live? We don't mean to suggest that you, or anyone, can take the reins and control how all of it is going to go. Part of the challenge is tempering that need for control. Death as a subject is not easy, and dying is not painless. We make no promises to the contrary, and we encourage you to run from anyone who does, as do I. But we do believe this book and this talk will help dying be less painful and more meaningful. And this rings very much true to me for the sake of many of my patients and their families, and also my own mom, who was under the impression that the fact that she wasn't cured from her cancer was a sign that her faith wasn't strong enough. And that really broke my heart. It really added this extra level of spiritual distress to what she was experiencing. And I remember I felt so confused. My family's from a Christian background, and I just thought, like, every single one of Jesus's disciples died. Clearly, the measure of faith can't be measured out by healing. And yet, this is the experience that so many people go through. And I would like to clarify, I really do think that I'm not somebody who says miracles aren't possible. I definitely think they can be, but also 2 things can be true at the same time, which is miracles are possible, and also death is a normal process. And no one should feel ashamed that the end of life comes. So we'll keep going. Okay. So hospice and palliative care, we really think of these 2 together. They really go together like milk and cookies, but they are very, very distinct. And I want to talk about those distinct differences. One reason why we talk so much about palliative care and hospice is because now we have a lot of research demonstrating that people who receive palliative care and hospice care experience less depression and anxiety. And we've also seen that it doesn't shorten life, which was a concern that some people had. Let's move on to palliative care. So palliative care is a specialized medical care for people living with serious illness. This type of care is focused on providing relief from symptoms and stress of illness. The goal is to improve quality of life for both the patient and the family. It is meant to be holistic, so not only just for the patient, but also for the family. And what we really want to stress is that palliative care is not about the end of life. It is about symptom management. And because of that, because palliative care and hospice rose together and had many of the same people advocating for them, in a lot of people's minds, people think palliative care equals end of life. And there can be a lot of resistance to participation in palliative care. At my institution, Cedars-Sinai, they actually changed the name from palliative care to supportive care medicine to kind of distance ourselves from that association. But it really is about symptom management, and anyone can have palliative care anywhere along that spectrum of cancer treatment. Our bone marrow transplant program, we used to actually connect patients to supportive care medicine as soon as they came in the door. But we ran out of bandwidth. We can't do that anymore. But that is the mentality, because we can see that research demonstrates that if you are connected with palliative care early, you are more likely to complete your treatment regime at the intensity that is prescribed and in the timeline that is prescribed, with that less interruptions and with less dose reductions, because we are able to manage those symptoms. So we'll go on to the next slide. Palliative care is symptom management. And underneath this umbrella of symptom management is going to be hospice care, because during the end of life, we really, really, really care about symptom management. We want people to be comfortable. We want them to improve their quality of life, but that is not the same thing as palliative care. So we're just going to understand that while there are many similarities, and there is a reason why they often get grouped together, they are distinctly different. And if it is an option for you, I would highly recommend you consider palliative care as an option. Also, because if you do it early, it gives you more opportunities and more options. So, just like anything else in medicine, palliative care isn't a magic bullet. And there can be mismatch in providers. Providers have different strengths. Doing it early allows you to learn those things. Also, the strength of the relationship is what allows for more creative solutions later on. And that's more of what we'll talk about as we go into symptom management. So let's go over to hospice. So, excuse me. So hospice care focuses on physical, spiritual, emotional support for those with life expectancy of 6 months or less, with the goal of increasing comfort and provided where you live. So there's nothing magical about the 6-month life expectancy. It's really just an arbitrary number, and patients can continually be enrolled every 90 days. So that was just something decided by lawmakers. It's not something to be too concerned about. If you have a serious illness, if it is terminal, it's a great time to think about hospice. Because of how high our property taxes are in California, we don't usually have the option to go to a hospice home. So there are 3 hospice homes that I am aware of in California. None of them are in metropolitan areas. But if that is something you're interested in, you should look into that early. So by legally, all insurances are going to cover hospice, and it is considered its own insurance. And when you go into hospice, it becomes much, much easier to get the devices that you need, even the medications that you need. There's a lot less resistance. So that's something that is much appreciated at this time. The focus of hospice is meant to be holistic, which means it really does include the family as well. And that's something that is much appreciated. There is, once again, we talk about considering this early, because like everything else, hospice is not a magic bullet. You're going to need to find good fits. Although we are glad to see that research demonstrates really high satisfaction for patients who go into hospice, not everyone is going to be satisfied. And so getting that information early and knowing what resources are available and what's a good fit is going to help. Also, 1 in 3 patients enrolled in hospice actually enroll a week or less before they die. This is very common in the hospital. We would have patients who come in and they would be switched to hospice, and then they would die in the next few hours or a few days. For some patients, that is the perfect amount of time to be on hospice. For a lot of patients, they missed out on a lot of support that could have really helped them. So please, be willing to think about that early. It is important to know that you will be foregoing curative treatment, because the goal of hospice is to increase quality of life and to improve symptoms. And so when they're looking at different options for you, they will think about, is this truly going to be helping your quality of life? So an example of that is going to be like a back surgery, a kyphoplasty, where the recovery is 12 to 18 months. If somebody's life expectancy is 6 months or less, it's not going to be in line with the goals of increasing quality of life and increasing comfort, when we really can just focus on managing that back pain rather than having someone go through this entire surgery. That is something to consider. But we would also see that if a patient has an infection, we are going to give them antibiotics, because infection causes a pain. Infection causes more symptoms and issues. And so we are going to be treating that. And we would have patients come in to the hospital setting as well. When their symptoms were not being managed outpatient, then they would come inpatient. And then when we got them under control, we would go ahead and send them back home. One more thing is that hospice care is not does not provide caregiving, and that's what is something that's very, very challenging for families, that somebody still needs to provide the care. What hospice can provide is ongoing support, and so we'll go to the next slide about all of the various things that hospices can provide. So what can the hospices provide? They can provide a hospice doctor, hospice nurse, hospice aide, social worker counselor, and that is available, and a grief counselor who is available for a year afterwards, after the passing of the patient. Chaplain, volunteers, physical, occupational, speech therapy. Once again, all of those needed equipment become very much more easily attained. 24/7 telephone support, sometimes not always. Some hospices are able to provide respite stays for caregivers, and around the clock nursing care for a day or two, not always available, but sometimes is. So once again, not going to replace caregiving, but will be providing extra support in the home. Let's move on to talking about symptoms. Okay, so what we want to talk about is that most discomfort is treatable. There is a very important mind shift that has to happen at the end of life, and in the case of advanced cancer, which is that if you have an incurable condition, it's going to come with incurable symptoms. And that is just to be expected. In the same way that we have the quote about if anyone tells you that death is painless, run. That's also kind of in the same vein. We do have to temper our expectations. But what we can do is that we oftentimes can do a lot to alleviate. We can do something. Most discomfort is treatable, even if it is not curable. And that is where we start to get very creative. Now, we are going to talk about the difference between acute versus chronic symptoms. Acute are going to be brief and severe, suddenly an increase of pain, suddenly an increase of nausea. These are the kind of symptoms where we need to jump on them, we need to act. An emergency department visit might be warranted, and we're going to do whatever we can to take care of that symptom. The chronic symptoms are a whole nother story, and it's more about what we will focus on, because chronic symptoms are par for the course when it comes to an incurable condition. They're going to be over time. They're going to be persistent. They're going to persist despite all of our despite efforts to improve them. And as much as it feels terrible to say sometimes, they don't necessarily need an urgent response, because going to the ED isn't necessarily going to move the needle very much. And because of this, patients can often report feeling a lot of hopelessness. But on the other hand, we have time. And time allows us to get to know and experiment and to be creative, which is what we are going to talk about. And that goes to our next point, is that you are the best judge. Only you get to say what works for you and what doesn't work for you. And for this, I'd like to say, there's a lot of things about science we just don't know. And you are an individual. You're not going to be the majority. Some things can work for you that don't work for somebody else. Also, one of the most well-studied phenomenons in science is the placebo effect. And it is a real effect. We actually have some research demonstrating that the body physiologically responds and does healing in response to placebo. So there was a study where patients were given pain medications or dummy medications for pain, and they found that a certain percentage of patients actually created their own natural opiates in response to the placebo. If it works for you, we don't question it, we are thankful. And who cares what anyone else says? Let's talk about how medications can cause other symptoms. Medications really need to be scrutinized. They are necessary, they're important, but we have a problem in medicine where we prescribe a lot and then everyone is afraid to unprescribe. Palliative care physicians and hospice care physicians tend to be really good at thinking about what is necessary and trying to shrink those lists down. And those can be really, really helpful. These interactions are really complicated, and that's where having a palliative care physician or somebody who knows your full case is really going to be helpful. In terms of alternative treatments, this is something that doesn't get discussed as much, but is so important because 80 to 90% of people with cancer will use alternative treatment, but only 30% will actually tell their physicians about it. And this is where I say, please, please, please tell your physicians about the various different alternative treatments you are considering or doing. I will tell you that I have never met a physician who has been adamantly against an alternative treatment unless they have a real scientifically backed reason to do so. More often, physicians tend to be more indifferent, more like, sure. That's the sort of a response that I see much more often. And our doctors, we understand that our oncologists and our palliative doctors are Western medicine trained. Their knowledge of alternative treatments is really going to amount to maybe a PowerPoint that they had in med school. They don't have that wealth of knowledge, and they know that. There are many other things that people can seek to experiment and look into, but we do please tell your physician because there are some things that we do just know. And some of those things that we know are, I had a patient who had a very, very hard consolidation chemotherapy regime and then a very difficult allogeneic transplant. We got her through everything. We sent her home. She was back in 48 hours with raging sepsis, and she had gone home and eaten a special delicacy, which was an embryo of a chick that was raw, and that was perfectly fine in 99% of circumstances. But in this particular circumstance, where she was neutropenic and had just gone through a transplant, it was actually really, really dangerous. So that's the kind of example of things that are perfectly fine normally, but sometimes we just know that there are some things that can be dangerous. And one last piece I would like to say when it comes to alternative treatments to balance out the conversation is that if somebody promises you the moon or tells you that something is going to cure cancer, it is my personal recommendation to run. Because this topic is from the perspective of a nurse, in the same way that we say this talk is meant to be realistic. And if somebody is promising you the moon, I would proceed with caution. Let's talk about our symptoms. Some of the symptoms that we have are anxiety and depression. This is an overall sense of worry or fear, difficulty concentrating, restlessness. Depression can be described as lethargy or having no interest. Truthfully, anxiety and depression to a certain extent are expected in a case of having advanced cancer because there are symptom burdens that come with it, because there is a lot to be considering, because you go into the hospital and we disturb all your sleep. Um, and what happens often is this illness turns you into a professional patient. You have to track all of your appointments, all of your medications, where are you going, insurance, all of these things. And in some ways, you can end up inadvertently cutting yourself off from the things that give you life, the things that give you joy. So often, one of the most powerful things we can do is just reconnect you with those things that give you life and give you joy, those hobbies, the people, those things. But sometimes it's medication that can be a great, great tool. So we'll look at all of those things. Go to the next slide. Here are a list of herbal and non-pharmacological options and medication, counseling, distraction, meditation, breathing exercises, guided imagery, which, by the way, I have had a lot of success in the short term. I haven't necessarily seen guided imagery be very powerful in the long term, but I would love to know people's experiences with that. Physical exercise. There is an incredible amount of research demonstrating that physical exercise has the same likelihood of effect on anxiety and depression as medication, actually. So that is, and that is free. And also can be very small depending on just whatever physical activity you can do comfortably. Energy healing like Reiki and Tai Chi are options, music therapy, animal assisted therapy, massage, acupuncture, craniosacral therapy, which is a gentle hands on technique that uses light touch to examine membranes and movements of the fluids in and around the central nervous system. Unfortunately, not covered by insurance, but some people find that helpful. Essential oils such as lavender, citrus, clary sage, bergamot, ylang ylang have been associated with improving these symptoms, and some herbs as well, like milky oat seeds. We have medications that we can go for, and sometimes they can be incredibly helpful. So we want to consider these as well: antidepressants, benzodiazepines, psychostimulants, and cannabis. When it comes to cannabis, I'd just like to say to please use your community and use your resources, your palliative care doctor, your oncologist, the Facebook group of cancer survivors, your support community, cancer support community, Los Angeles. Not all cannabis is created equal. There are many, many different strains, and it is not a well-regulated market because of all of the legal behind the scenes. And so because of that, we do ask, please use the community and the resources around you. Confusion is a very common part of advanced care illness and doesn't get talked about as much. All right, so the next slide, I'm going to go into confusion. Yeah, thank you. So another term that's used is delirium. Someone can be unaware of themselves, person, place, or time. It's very common in the hospital or actually in any unfamiliar environment, and becomes more and more common as cancer progresses and becomes closer to the end of life. When sleep-wake cycles are disrupted, which equals being in the hospital, there's so many different sources: infection, neurological conditions, insomnia, uncontrolled symptoms can cause confusion. Medications, liver, kidney disease. This symptom confusion is often waxing and waning. So it comes and goes, it's stronger and less strong. Sometimes it can get worse at night, and that term is called sundowning. And it can even express itself as being hypoactive. And often families are the ones to pick up on something being a little bit off about the patient. And what we really want to say about this one is that we do see that patients sometimes don't actually tell providers that they are experiencing confusion. And I just want to say that it is actually very normal and it is expected in advanced cancer. And it is helpful for our providers to know if confusion and delirium is coming, because there are oftentimes things we can do about it, particularly if we can find the source. Sometimes there are medications that are causing or exacerbating or worsening things, and then we can see about what we can do about it. When it comes to our interventions, some of our non-medical interventions include supporting the sleep-wake cycle, which is incredibly important. And so even things like opening up the windows so that you can see the sunlight actually, and turning off lights during the nighttime can make a huge difference. Reorientation, and we like to do this instead of very non-confrontational. We just go ahead and talk with the patient and talk with things that are familiar to the patient in a casual conversation and about current events. And no judgments, no strong reactions. That tends to be the best to help patients to reorient themselves. Surrounding the patient with familiar objects can be really helpful. Having a clock in front of them, they can reorient themselves by seeing the time. Ambient essential oils such as rosemary, vetiver, citrus, and basil have been known to be helpful, and acupuncture is also an option. And we have some medications as well that sometimes can assist, and especially in terms of calming somebody who is feeling confusion can come with agitation. With constipation, this is a big one for me. If I'm your nurse, oh, sorry, we're gonna move the slide forward. For me, if you are my patient and I call you on the phone, one of the first things I'm going to ask you is how your bowel movements are doing. Pretty much everybody tends to underestimate the impact of constipation on the body and people and how it affects all the rest of you. Constipation can cause pain, nausea, loss of appetite, shortness of breath, fatigue, delirium. And it is something where we often can do something about it. It can be a medication side effect. It can be caused by the fact that you're less mobile when you're sick, nervous symptom dysfunction, dehydration. You are nauseous and not drinking as much, and then you get constipated. Something to keep in mind is that we are seeking for the goal of what your bowel movements look like before you got sick. Even though you might not be eating as much, there is going to still be regular sloughing of the mucosal lining, and that needs to come out. And so there should still be some movement happening, even if you're not eating very much. And it's interesting to know that diarrhea can sometimes actually be a harbinger for constipation, because it can be, you can be stopped up and the fluid can be seeping around it. So sometimes we've got to do more examination. I would encourage everyone to act quickly. I hope that everyone is on a bowel regime, or that you have what you will go to if you are not having a bowel movement in the timely manner that you would like to or are used to. And personally, because I'm conservative, I tell my patients, hard stop at 5 days. If you've already escalated your bowel regime in that 5 days and nothing's happening, you pull out that enema. You pull out the enema and see what happens. And if it's not helping, then you take yourself to urgent care, because you have too many problems for this to become another emergency. So that is a conservative suggestion, but I will say, don't let constipation move quickly, and it will be less of an issue. So when we talk about non-pharmacological interventions, huge one, hydration. huge one. You need to stay hydrated. And oftentimes people stop monitoring how much they're drinking and you don't actually realize. So keep in mind about that. Warm water with fresh lemon or lime juice can be helpful. Chewing fennel seeds, mobilization, abdominal massage, acupressure, reflexology, prune juice, biofeedback, and other relaxation techniques. Homeopathy, flaxseed oil, and herbs. Senna is a common one that gets prescribed. We do have laxatives as well. Laxatives work in different ways, and fiber also has different types of fibers. So for this one, I do recommend getting just running it by your doctor, just making sure that it gets discussed at some point, because they all do different things. And really important thing, especially with anything that's fiber related, is that you are drinking well. So please make sure that that is happening. And we've got some other medications as well. When it comes to diarrhea, which is our next symptom, it's important to keep in mind that there are some treatments that actively encourage diarrhea. And so something that we hear a lot in the cancer world is C. diff or Clostridium difficile. And if that is an infection that you have that has a spore inside that keeps it from being destroyed as easily, we actually need you to shed a lot of that out. And so that can be too with a certain kind of liver conditions as well. So there are times when we are not going to be wanting to stop that diarrhea. But there are things that we can do. So you want to go ahead and talk with your doctor. And with diarrhea, we always want to consider incontinence and skin health and whether or not we need to change our medications. So here are some things to consider: slippery elm, aloe vera juice, carob powder, probiotics, fermented food, bland foods that are not going to irritate and allow the stomach to rest and the gut to rest. Electrolyte and fluids, because you are losing a lot of this in the diarrhea. Chamomile and peppermint tea, once again, things that relax and rest. Oversteeped black tea. And then there are medications as well. You'll see tincture of opium. That one is because we know that opiates are a big causer of constipation. Sometimes we go ahead and use that to our advantage and say, okay, let's go ahead and see if we can use that to stop diarrhea as well. Dry mouth xerostomia it can become as common in advanced disease. So that's our next symptom there. A source can be dehydration, poor circulation, breakdown of glands, too much bacteria, and medication side effects. It can also be thrush. So you want to take a look inside your mouth. Are you seeing patches? Especially like white patches is what we typically call candida infection, because we can do something about that. So what sort of things can we do for dry mouth? Warm tea and lemon can kind of cut through that. Mouthwash, although I will say I don't tend to be as big of a fan of mouthwash because it often has alcohol and is drying. However, if it's working for you, that's amazing. But I tend to veer on recommending something like biotin, which is a mouthwash but has artificial saliva in it and can prevent some of that drying. So increasing that fluid intake, we talked about acupuncture, lip balm, artificial saliva products like biotin, tart candies, lozenges, ice chips where you can suck to improve that function. And there are certain foods that as well can be known to assist, and swabbing the mouth with glycerin. We don't have a lot of medications, but there are a few that we can try, so it's always worth it. Fatigue is a very common symptom as well, and this is when resting doesn't improve this exhaustion. And some of the sources are going to be anemia, insomnia, infections, depression, uncontrolled symptoms, medications, chemotherapies, radiation. 100% of patients who get radiation will experience fatigue. And you might be surprised to know that one of our combats for fatigue is actually exercise. Exercise has been known to decrease cytokines and decrease the inflammatory response in the body, and is actually an important part of cancer rehabilitation. So that can be something that you might want to consider incorporating to the best of your abilities, to whatever is comfortable. Sleep hygiene is huge and much more difficult in this day and age where we have a lot of screen time and in the hospital when they are interrupting you constantly. But that can actually make a really, really big impact. Social engagement, breath work, yoga, massage, energy healing, avoiding caffeine, essential oils, animal assisted therapy, craniosacral therapies. And we have medication as well that we can go ahead and try. Psychostimulants is one that I have seen our palliative care doctors prescribe in particular. The next symptom we're going to discuss is hiccups. So fortunately, not a super common one, but nevertheless can happen and it can be really distressing. I'm going to go through this real quick because I'm running out of time. But what I just want to emphasize is just that we actually have things that we can try for this. I hope that this doesn't become an issue for you, but if it does, just know that we can, and I have given medication. Itchiness, pruritus can be caused by biliary tract disorders, bed bugs, skin infections, psychiatric conditions, kidney disease, swelling, HIV, neuropathy, opiates, eczema, dry skin, medications, a lot of different things. And so we're going to do whatever we can. We're going to pull it in. Light therapy, which is something that gets used for eczema, can be helpful. Emollients and moisturizers, Arna lotion, skincare, avoiding irritants, having a cool environment, sometimes even putting your moisturizers or skin topical things in the fridge to cool them down so that that also assists when you're applying them. Distraction, homeopathy, applying a mix of lemon and apple cider vinegar and water, colloidal oatmeal baths. And we have topical medications that we can try as well. When it comes to loss of appetite, also known as cachexia or wasting, this one is challenging. Food is often a very emotional topic during the end of life. Cachexia is involuntary weight loss and can be caused by chemotherapy, medications, mood, activity levels, nausea, vomiting, and is a natural part of our body as we are dying. And so when cachexia comes, it is often becomes a sign that death is coming rather than causing the death. And that's something that we need to be aware of because it is a very common sentiment, a very natural instinct to worry that your loved one is not eating enough. And we hear it all the time that, thy loved one is starving and we're going to starve them to death. But we see that this becomes a part of the body becoming incredibly efficient all the way to the very end and using all of the stores in the body because there becomes a time when outside nutrition no longer becomes useful or helpful. And so at that time, what we really recommend is to encourage and not to force. We do things like repositioning to assist with swallowing, adding fat to the diet. This is the time we say, pull out the ice cream. Eat whatever sounds good to you, feels good to you. Chew to savor and spit if you don't actually want to swallow. Cook for that scent or symbolism. You eat for pleasure. Small portions and smooth textures tend to be less intimidating. Try adding sweetness because sweet is one of the first taste senses that a baby experiences. It is very much forward and we can go ahead and give that a try. We say encourage, don't force, because again, it's not actually going to benefit the patient. We have no research demonstrating increasing life or increasing quality of life as well. And we have medications that we can try as well to go ahead and try to stimulate appetite. With nausea, there are so many things that we discussed can cause nausea: constipation, pain, headache, hunger, low appetite, anxiety, reflux, chemo, grief. Note that our mucosa gut comes from our mouth, throat, esophagus, stomach, all the way to the rectum, and one part can affect the other. So we are going to be thinking about how you might feel nauseous. It often comes with other symptoms and can be affected by what's going on in the body. Some things we can try: ginger, peppermint, chamomile, fennel tea, sparkling water and grapes, acupuncture, acupressure, those anti-nausea wristbands can be helpful. We have a lot of medications that we can try. We're super thankful for them, but they do also potentially have side effects, and that's where our palliative care doctors really, really come in to be really helpful so we can balance all of those things out. Pain is both physiological and has a neurological pathway, and we've got to consider both of these. And neuropathy is one that we talk about more when it comes to cancer because it's regardless of that physical stimuli, the nerve itself is sending these signals. And often at the end of life, when it comes to serious pain, we focus on medication as our primary tool. But there are still things we can do. So let's talk about it. You'll see on our next page, we've got a lot of different options. And what I want to say here is some of these are going to make a lot of sense that you would have thought, but we get very creative. And one of the things about all of these medication options that we have that I'm so thankful that we do have is that they do come with side effects and can cause sedation and confusion. And so it's this balancing act that we are working with. And sometimes what we do is maybe we choose to not go up on certain medications, but we'll try to be more creative. We'll take the biofeedback, behavior modification, psychotherapy. We'll take those perception angles so that we can try to work on that experience of pain and the mood that involves pain because we've hit a limit of where we want to go with the medications. There are ways that we can do to improve our patients, and also sedation is an option. Patients who died in the hospital on hospice, we would go ahead and sedate them so that they can be comfortable, and that is an option as well. Shortness of breath is something that is called dyspnea or air hunger. My mom experienced a lot of this, and it can happen even if the oxygen saturation is normal. And it's important to remember that shortness of breath and anxiety are like cousins. They come together because if you are having trouble breathing, that is going to naturally come with anxiety. And if you're anxious, that is going to make you short of breath. They come together. And so some of our interventions are going to consider that. Things like ambient airflow. Positioning is going to improve the flow of breath. There is this tripod position where you are sitting up and moving forward, and my mom actually slept in that position at a certain point. Breath work, guided imagery, all of these various things. Opioids and benzodiazepines become very important, very helpful, and can really decrease the work of breathing and assist with that shortness of breath. When it comes to skin breakdown, we really talk about preventions. When it comes towards the end of life, then those any wounds that occur, we are really talking about a comfort at that point. And so what we're going to do is for skin breakdown, we're going to want to inspect daily, stay clean and dry. We're going to pad any places where there's going to be pressure on them. If you're in a wheelchair, you want to reposition. We often put pillows between legs and between heels so that rubbing doesn't happen, or even that rubbing of the heel on the bed. Prevention is our best option. But if that wound comes, and if it is towards the later stages, towards the end of life, we really focus on keeping that wound from getting worse and pain management. Taste changes can be very, very stressful. And what I want to say about taste changes is that often this comes to being creative and being willing to explore and change the way we think about things, because often the best thing we can do is optimize the taste function that remains. So this fast diet, if you go to the next slide, looks at the functions that you have and how you might feel and things we can try to do to rejigger your taste buds and your experience. So if something's tasting too sweet, how about we add something sour? Too flat, try to add something sour or sweet. Too spicy, add fat or add sweet. Too spicy, add sour. Too bland, add sour, add salt. Too bitter, add sweet. So we're going ahead and we're just going to work with what we have in order to make this experience more pleasurable. And we do find that patients tell us that they are often surprised that things that they didn't like previously now are working for them. And that is what we want. We want that creativity. Let me go through the timeline at the end of life as fast as I can. So, the weeks before death, we're going to see social withdrawal, a lot of introspection, increased sleeping, decreased appetite, weight loss, fragile, easily damaged skin, general pain. These are things that we expect, and that's why we focus on symptom management at the end of life. Days before death, we see a drop in blood pressure, changes in skin color, cooler hands and feet, fewer bowel movements and urination. The whole body is slowing down, circulation is slowing down, and we see that. There's a decrease of appetite and fluid intake. There is something called a death rattle where fluids can accumulate in the throat. And that one, we see that when the death rattle comes, the average time of death is 23 hours. So that is an indicator usually that death is very close. And for that death rattle, we don't have any research or evidence to say that it actually contributes to patients' discomfort. We often treat it more for the sake of the family because it can be disconcerting to hear this while you're sitting at the bedside, but know that that is normal. We do see deliriums and hallucinations, and this actually becomes more increased in frequency closer to death. And so just keep that in mind that your loved one might be saying some things that are not typical for them. Days before death, you can get a sudden burst of energy that fades. That one I like to point out because if it comes, please enjoy it, make the most of it. Uh, and sometimes family members get very excited, thinking that, like, oh, my family member is getting better, my loved one's getting better, but not necessarily. So just remember that if it comes, enjoy it. Skin becomes increasingly mottled and blotchy. There's a further drop of blood pressure, inability to swallow, less urine, increased restlessness, labored breathing, increased congestion, which includes possible fluid secretion. Hours before death, we see glassy, teary eyes that may be half opened, cold hands, weak pulse, increased hallucinations, sleeping and unable to be awoken, so unresponsive, breathing that's interrupted by gasps or may stop entirely. We get this agonal breathing, we call it, where it's a deep breath and then a break, and you don't see that for a while, and then another breath. That's called agonal breathing. So, how do we know when a loved one has passed away? When a loved one has passed away, certainly going to be unresponsive. There's other things that can cause that, but certainly in death, you're going to see that breathing stops. You can put the hand to the nose and the mouth and feel for breath. Often at the end of life, people become mouth breathers. And so it's the mouth more than anything that you want to feel for. You can also listen for a breath. You look for a pulse on the carotid, the wrist as well, but the carotid is going to more likely be more accurate. And the eyes and the mouth will naturally open often. And so something that we do for our patients is we would close their eyes, and I would even use a ribbon to close the jaw so that when rigor mortis sets in about 4 to 6 hours, that body would be frozen with the jaw closed and the eyes shut. And so that's something that we would do for our patients and families. I'm sorry to speed through that so quickly, but I am just going to end with this quote that you matter because you are you, and you matter to the end of your life. We do all we can, not only to help you die peacefully, but also to live until you die. Because while we talk so much about death, hospice and palliative care is actually about maximizing living. So thank you so much.
Sarah, thank you so much for this meaningful conversation. We appreciate you so much and taking time to spend with all of us today. I know we're at the top of the hour, but let's take a couple of the questions, and then, as I mentioned in our opening, we will end, I'll invite Kristen O'Leary-Jones, our development director, to come on. She has a couple things she wants to share. Someone is asking that you mentioned a grief counselor is available for a year after death. Is that for anyone in the family or only those who are in the home with the person?
My understanding is that it is anyone who is family member. I don't know if I don't believe it can extend to a friend of a family often. Although if the caregiver is not a family member, I think oftentimes that person can access that support. But yes, it should be for any family member.
Great. And then another question is, can you repeat what you said about the placebo effect? And
Yes.
yeah, the body creates its own, and the person has a blank.
Yes. So we have seen that with the placebo effect, sometimes the body physiologically responds and sort of healing itself, one might say. That was the word that was used in the research, at least, where it's basically like, so for this study was patients were given a pain medication and some patients were given the dummy medication. Everyone was fully aware that that they might get the dummy medication. But even the patients who got the dummy medication, a, the same amount of percentage of people who received that dummy medication experienced pain relief. And they actually looked at their blood and saw that the body was creating natural opiates in the body. So that's why we say the most well-researched effect is the placebo effect. We have so much research demonstrating that patients feel relief on things, even if they don't have whatever content it is. Maybe some of that is psychological, maybe some of that is physiological. We know that it happens. And so if it works for you, we are not going to question it. We are going to embrace it and we're going to be super thankful about it. So who cares what the science says? Works for you? Go for it.
That's terrific. Thank you. And then I think I'll end with this. At registration, we received a lot of questions about how to have end of life conversations. And in your experience as a nurse, what are some recommendations you can provide us? Maybe some tips, some insights
Yes.
about how to have these conversations.
Yes, I think, of course, every person is different. And so some people are more comfortable with a direct approach, more people are comfortable with an indirect approach. If there's someone that if it's a loved one and you are unsure about their comfort level, I actually recommend discussing hypothetical situations, maybe sharing about someone else's experience or things like that, and see how that person is responding. That can often give you a gauge as to their comfort level and their willingness and their openness. Um, Oftentimes, what we would do as well is we would just reflect back what we are seeing. And so, we're seeing physiologically, what we have seen as time has passed, and that sometimes can help the person to self-reflect and to think about where they're at on their own to kind of assist with that process of going there and having those discussions. Um, Often, talking about end of life, it can also be another kind of way of coming at it at a different angle that can be helpful is to discuss that there are many other cultures that deal with end of life very, very differently. So you can talk about, say, the Swedish culture, where they actually talk about a natural process of decluttering towards the end of life. And so they're looking into giving away the things that they want to give away and to designate where they want certain things to go. And like, is that something you're interested in? Like, is that something that would be why is that something that we can do? Coming at it from different angles can be very helpful. For some people, it is that direct conversation that they are craving, but it really is going to work as that relationship that you're building and talking, where you see where that person you're talking to is at.
Thank you. And there are several comments in the Q&A saying from those who are participating what a wonderful presentation this was. So on their behalf and behalf of CSCLA, thank you so much for your time and sharing your expertise. And I want to invite Kristen to come on. And Kristen, if you want to unmute, turn your camera on, and we have a slide that we're going to share. And I will give you, I'll give you the floor for a couple of minutes.
Thank you. Yeah, I'll be quick, recognizing we're over the hour here. I'm the development director at Cancer Support Community LA, and I just wanted to make sure everyone is aware of our Benjamin Society, which is the key donor for our end of life educational series, such as the webinar that you just sat in on, and our other end of life programming. And so for those who don't know, the Benjamin Society is a group of donors who have pledged to leave a gift in their will, as well as gifts of stocks, life insurance policies, etc. And so we recognize during the end of life, while you're thinking of health options, you're also dealing with the estate side of things. And so we hope that you'll consider including Cancer Support Community in those estate plans. It's a key piece of funding that allows us to offer all of our programs and services and counseling, health and wellness classes, all of the wonderful things that we do for free for cancer patients and their families. If you would like any other information about the Benjamin Society, you can reach out to our team with this development at cancersupportla.org email address. And we also have some resources on our website as well. So just wanted to give that little plug. Thank you so much for joining us.
Yeah, thank you, Kristen. And Abby, maybe we can put the development at cancersupportla.org in the chat, as well as our info at Cancer Support LA. And we have reached the end of our time together, and we want to thank Sarah again for her participation, for her thoughtful presentation, and thanks to you, our attendees, as well. And we hope to see you at an upcoming webinar. Thank you. Have a great day.